Chuck made aware that it was no sound with those. When they moved to the new projector,
That's what I thought.
it cuts out all the audio, so I'm assuming you have a video, okay? So if you wanna post it to the group me or whatever, or if you wanna send it to me and then I can put it in Canvas too, however y'all wanna access that, seek out. No.
The playlist should be current as of right now. so.
Okay, good, because, when I clicked it through, it was just nothing but static, I was like, oh. Anyway, yes.
Can a nurse milk the line unadjusted?
No. We're gonna go with
Test
test.
purposes, no.
Test purposes, no.
Okay.
I mean, I feel like that question should be definitely answered. That'd be an easy 2 points for us.
Maybe, because I don't have any control of the test system, so.
Please don't start.
It's all your content.
Canvas.
Did you see it happen in practice?
No, on the
The
quiz.
bonus questions.
The quiz, it is we can.
Okay.
Extra credit.
But only because I knew that, I put true, because I might
Dollar
have
percent
turned
you
that
could.
around.
Yeah.
And I got that question right,
Um,
so, don't go
We're
back and
not,
change
we're
it.
not continuously milking, we're not, mostly it's kind of like a gravity feed, like you almost do with your urine, and so you'll just kind of look it up.
I've seen that,
Kinda.
but I just asked because of the.
But extensive stripping and milking, it can cause a lot of other issues, and so you should refer that to the NP or the MD, unless the MD or nurse practitioner tells you to do it. To break out some of those clots and stuff. Any other questions? Yes.
So when I was doing the ABGs, it was like, so the answer would be like respiratory alkalosis, and then it kept popping up that technically, according to science, technically the underlying condition is metabolic acidosis, usually.
Right, so when you, on the quiz, when it was like the 3 parts.
Yeah.
Yeah, I got the first 2 right, and then the third one is like, no, not right.
Yeah, it would say that, I think, I'm
It
pretty
depends
sure.
on what metabolic process or what respiratory process is trying to buffer that pH, and that's how you gotta think about it. So if you have respiratory alkalosis, or let's say respiratory acidosis, pH is low, CO2 is high, all right? I need my bicarb to go up, right, to cover or buffer my pH level. When my bicarb is up or elevated, what disease process or ABG is indicated?
When your
Bicarb is up.
Okay.
Metabolic wise, when my bicarb is up,
Is metabolic.
alkalosis, right? So metabolic alkalosis is
Oh.
compensating to buffer my pH on my respiratory.
I know it's the
acidosis.
opposite, but it was just simply saying like, in a situation where there's respiratory alkalosis, in practice, technically the condition is usually metabolic. When it's respiratory alkalosis, usually the underlying condition is metabolic acidosis. So I was like,
Yeah,
this is
yes.
super confusing.
Because, the big one is gonna be like DKA.
Yeah,
That's gonna be your metabolic acidosis type syndrome. But in DKA, you're breathing off a ton of CO2.
mhm,
So you're doing this, what's called Kussmaul's type breathing. So kind of like pregnant women breathing.
okay.
A little bit faster, so it's a distinct pattern. And as you're breathing, you're hyperventilating, you're blowing off that CO2. And so then
So
your
although
pH is
it's
gonna-
breeding the respiratory alkalosis,
Yeah.
that's probably not the underlying condition.
For your test purposes wise.
It's going to be.
It's gonna be that slide that says what causes what.
Okay,
The ones you're talking about is like a mixed gas, so you can have lots of factors playing into one thing, and we're not getting that complicated. with
okay.
it.
I was just like, why is it doing this to us?
There's a lot of variations of what we're looking at. We are breaking it down to the real basics
Okay,
to.
so just keep it basic and move
Mhm.
forward. Okay.
Okay. Let's do a couple case studies first. These are really gonna be talking about your pneumos, lung surgeries, and like chest tube placement, really to kind of get you to brainstorm and think about why we're actually doing this kind of stuff, what kind of complications we could have. And if we do have those complications, what can we do for those complications, okay? This case study and the review quiz game that we're gonna play will be on Canvas as well. So you don't have to take notes unless you just want to. All these questions and all this stuff will be on Canvas for you, okay? Oh, is my clicker not gonna work tonight? It's not. Alright, so let's look at this. We got Mr. James Thomas, he's a 56-year-old male. He's 6 foot, 185, septic shock secondary to urosepsis. He's got a past medical history of hypertension, chronic kidney disease, stage 3, 20 pack a year smoker, and he's got some hyperlipidemia. Currently, he is intubated and sedated in the ICU, and he's on a norepinephrine infusion. Anything stand out to y'all as far as this goes?
He has 20 packs in that group.
Okay, that's probably significant, right?
Stage 3 kidney disease.
Okay, good. Anything else?
Some septic shock.
Septic shock. He's intubated and sedated, right? So I gotta start thinking about my ventilator safety. That's probably a big one. Norepinephrine infusion. Can that go through a regular peripheral IV?
Yes.
It can, up to 8 milligrams, and then after, or concentration wise, 8 and 250. After that, it's gotta go through a central line. So we'll start thinking about central lines, potentially. Let's go a little bit further, get some more detail. So here's our background. Jason Thomas was admitted to the ICU for management of septic shock due to the need for vasopressor support, so that norepinephrine, and frequent blood draws. The provider ordered a triple lumen central venous catheter to be placed in the right subclavian vein. The bedside nurse assisted the physician with the sterile procedure. Okay. As I'm assisting my physician with a triple lumen or a central venous catheter placement, what are some things that I need to consider?
You can have the latrogenic pneumothorax.
Okay, wow, all right, big words, sounds good, I like it. What else? Anything about placement wise? What kind of things do I need to look out for? What do I need to assist my physician with in the immediate initial placement of the central line?
Supine,
Supine, okay, good.
slightly down to make sure maybe have some jugular extensions so we can get in there.
Right, so I wanna put my patient in supine, or even further back a little bit. Really, I'm trying to get kind of that blood flow up to the head, if you think about it, and really get that jugular vein distension almost, really to kind of beef up or pump up that vein so he can hit that instead of the carotid artery, because that's kind of important.
Make sure.
What else?
Vitals,
Vitals, what about vitals? Anybody?
make sure the lungs free.
What now?
Dysarthria.
Dysrhythmias, why?
Because it tickles it.
Right, good. So as I'm placing that needle, and then as I'm putting the guide wire through that needle, I'm causing potential some dysrhythmias because I'm going into the right atrium, and if I go a little bit too far, I can go into that right ventricle. So I might have a couple of beats of PVCs. All right. How many PVCs is too many?
Over 6 of them.
Over 5, right? That's considered VTAC. Now, if in the real world, if you call the physician and say you had a 5-beat run of VTAC, he's gonna be very mad at you, okay? When you start getting the 20s and 30s range, that's sustained VTAC, that's when we need to start letting somebody know or do some intervention, okay? But they are not gonna be wanting to be woken up over a 5-beat run of VTAC. But if he's at the bedside, placing the central line, he's placing the guide wire in there, he tickles that right ventricle potentially. You start to see a lot of ectopy or a lot of PVCs on the monitor, so I'm sitting here watching that bedside telemetry monitor, okay? And if I see that, I can tell him, say, hey, I'm starting to see a lot of PVCs, I'm starting to see some rhythm changes, and he'll be like, okay, and he can actually pull that back a little bit and say, hey, what does it look like now? And he can actually relieve it that quick. Because the main thing, the main malfunction, the reason why it's not beating like it should is because of that guide wire in that area. And hopefully that is all that he has to do with that. Speaking of vital signs, what other things could I look at? What's another big one? oxygen, right? O2 sat. Instead of going into the JVD or to the, not really a JVD, into the right internal jugular, maybe he popped a lung instead, right? So that could be something I could look at. During the line placement, Mr. Thomas became tachypnic and desaturated from 96% to 85% on the ventilator. The nurse noted diminished breath sounds on the right side and a drop in blood pressure, MAP less than 60. What is our differential diagnosis? Or what are we thinking about? What could be our major malfunction?
Latrogenic pneumothorax.
Okay, so latrogenic pneumothorax potentially. PE,
Latrogenic?
latrogenic, some type of procedure that caused a pneumothorax.
Oh, okay.
I studied last night, so.
Popped a lung, okay, how about that? We'll just pop a lung. I heard P in the back, I like that. What else?
Okay.
Remember, he's on the ventilator, right? We're moving around, doing all this kind of stuff. What could have happened to the ventilator?
Could've moved.
Kinda got disconnected, right? Maybe just from the ventilator itself, it could've just popped off and you didn't hear the alarm because you were focused on something else. Maybe you walked out of the room and were a bad nurse. Oh, then you came back. What about the ventilator itself? Can it fail?
Absolutely.
Yeah, never rely on your equipment too much. Sometimes then things just shut down and they won't cut back on. And then you're just like, well, all right. And then you have to move on. You have to fix that kind of stuff, all right? What about the endotracheal tube itself?
Dislodged.
Could it move?
Mhm.
Right. This one right here, let's see. It says sounds on the right side are diminished. But if I said left side diminished, maybe it moved too far. Now I have a right main stem intubation instead. And now I'm not oxygenating or ventilating that whole left side. Or, again, I moved it too far up and don't have that good adequate seal, and now I am only oxygenating or ventilating that left side. So tube dislodgement could happen, ventilator issues, Natalie's famous word there, the pneumothorax, where we just popped a lung. So it could be a couple different options. So, when we see this, what do I want to do about it?
Get a chest x-ray,
Get a chest x-ray. Okay, good. I like that. Why?
because it'll show you if it is the lung popped or if the placement's wrong. It'll show you everything you need to know.
It'll show everything that we just talked about, right?
It's not dropping too low either, it's on 85.
We could potentially look at the ventilator first, make sure nothing's wrong with the ventilator, that it didn't cut off. There's no kind of pressure alarm or pressure settings that are going off. But a chest x-ray is gonna show us a lot of different things. It's gonna show us that pneumothorax, the tube dislodgement, if it's moved. Remember, it's gotta be 2 centimeters above that carina. But if it's not, then we need to call the physician and make sure he can put it back in the right place. Yes, sir.
If it did just dislodge, would that, the little indicator bulb that kind of hangs out that you were showing us in ICU, would that?
Pilot balloon?
Yeah, the pilot balloon, would that reflect that it was not pressurized properly? Like if it wouldn't?
Potentially depending on how narrow or open the airway is, but for the most part, that pilot balloon is only indicating whether the balloon at the end is inflated or not, the cuff at the end of the endotracheal.
So it doesn't necessarily monitor the pressure that it's holding at, technically?
Not really, unless you have this special little device that you can use. But for the most part, all that's focused on is if the balloon or the cuff at the end of the endotracheal tube is blown up or not. But how can I tell tube dislodgement from my endotracheal tube?
If you look at the placement from the teeth.
Placement on the teeth, right? The numbers, remember those? That's kind of important when initial assessment. As soon as I walk in the door, do my assessment for the day, I know my patient's intubated. I've got to look at where it's marked, where it's measured. So, and then also the size. So maybe it's a 7.5 OEE2 tube, endotracheal tube, and it's measured at 22 at the teeth or the gums if they don't have any teeth. A lot of facial edema can happen. You can have lip swelling. Angioedema, you can have those kinds of things, so I need to make sure that I have a good, accurate measurement. Make sure that the tube is secure. But we got a stat chest x-ray, and it revealed a right-sided pneumothorax. So our suspicion was confirmed. I have a right-sided pneumothorax. Now with that information, what am I gonna do?
12 days new decompression.
Well, that would be if it was.
That would be for what?
14 days.
That would be for attention pneumothorax.
That would be for attention pneumothorax, right?
But essentially, that's what you're going up with.
A chest tube is what we're looking for.
Eventually, but we're not getting to attention pneumothorax yet, just a normal pneumothorax.
You're gonna set the patient up high Fowler's and expect them to put in a chest tube.
Expect them to put in a chest tube, okay? How or what positioning should I get my patient in for chest tube placement?
So it'd be right-sided.
It's a right-sided pneumothorax, so
So right side of,
That's right.
So if
So
you
left
left
lateral.
lateral.
left lateral, right? I need to get them up and above. What about my arm? Above the arm, alright? I gotta get a good visual of those intercostal spaces right there, okay?
That's one of my yoga poses, as a matter of fact.
So that's where I need to be. Really, this is gonna be an emergency type of situation, so consent's really not an issue with this, more under emergency protocol. I can also get my chest tube supplies ready. Remember, I gotta get that atrium ready. I gotta get it hooked up to wall suction. I gotta put the sterile water inside the atrium as well. So there's a lot that I can do before that physician even steps foot inside the room. As soon as he steps foot in the room, he should be able to clean, should be able to make his incision, shove that chest tube in there, and then you're gonna connect the atrium to the chest tube. Yes.
On consent, if they're unconscious, is it implied consent?
If
Based
it's,
on their wishes,
if it's an emergency situation.
even if it's not a,
Then you would get your next of kin, or you would get the medical power of attorney to sign off on your consent. Yep. Alright, so for Mr. Thomas here, provider immediately placed a right-sided chest tube in the 5th intercostal space, mid-axillary line. The tube was connected to a water-sealed drainage system, and the patient's oxygenation and vital signs improved gradually after chest tube insertion. So with this one, see this right here, this is our left side. You can see how you can see this kind of whitish gray, almost smoke appearance to it. That's gonna be all your when you're inhaling, all your air right here. And then you can kind of see the outline right through here where your lung is not fully expanded. And you have all this kind of dead space. So that's a pretty big pneumothorax right there. That's what you want to look for on your x-ray. You're not interpreting x-rays, but a good habit to get into it, to think about what I'm actually seeing. Physicians making that ultimate call though.
pneumothorax. I thought it was second intercostal and hemo was 5th.
Depending on where it is occurring. Usually they're gonna go up higher, but hemothorax, you can go lower and you can go higher too. You can have some consolidation and blood up in the upper regions and they'll go up higher.
Okay.
But typically it's gonna be in those places, yeah. Alright, so remember, during your central line placement, assist in setting up that sterile field. Make sure you have all your supplies handy. The main thing is, you are just kind of the workhorse. You're not touching anything blue. You're gonna put on one of those fancy lunch lady hats. You're gonna put on that mask, alright? So you're staying sterile. And then you're really just kind of opening up packages as needed. Most everything comes in that central line kit, except for a few things. Sometimes they don't have sterile flushes, and sometimes they don't have those little max caps or the little injector caps that attach to the central line itself, okay? Ensure a timeout procedure is performed. Sometimes we do this, sometimes we don't. We need to get in a better habit of doing this. It's supposed to happen, but who knows, okay? Timeout procedure. They're gonna say, hey, this is Mr. James Thomas. He's a whatever male he was, whatever age he was. We're doing a right central line insertion, and then you'll go through the process to make sure everything's safe and accounted for. It goes a little more in depth than that. Jess could probably talk all about a timeout procedure because I'm sure she does it often. But for the most part, right patient, right place, right procedure, that kind of stuff. Make sure we're safe with it. Signs and complications. So remember that dyspnea, the hypoxia. So maybe we popped the lung. Maybe the vital signs as well. We are tickling that right ventricle too much. With that, monitor your O2 sat, your respiratory effort, again, your vital signs. And then for central line placement and for really chest tube placement as well, endotracheal tube placement, those types of things, chest x-ray is going to be the best option for you. Yes, you can initially get some blood draw or blood return from your central line. More than likely you're in the right spot, but you don't know for sure. So you're gonna get a chest x-ray. Same with your chest tube. You really need just to confirm placement with that. Endotracheal tube, you're gonna listen for lung sounds, of course. Make sure you have equal bilateral breath sounds, so the left side and the right side. Make sure they're not diminished on one side or the other. Make sure you kind of listen to the belly as well, and we're not ventilating the belly and introducing a ton of air into the abdomen. And then we're also gonna get that waveform capnography, or that CO2 detector. That's always important. You'll probably see that at some point. CO2 detection as well. After that initial thing. And then, as they're placing it, I'm putting in that chest x-ray in already because I know I'm gonna need one. So hopefully, by the time I intubate, Zach's coming up with his portable little chest x-ray machine to get that chest x-ray. And then it usually has a little screen somewhere on there that the physician can walk by and say, yep, good to go, okay? I cannot use a central line until the physician says it's okay to use after that central line placement confirmed by x-ray. And sometimes they'll say, yeah, you can go ahead and use it, but 9 times out of 10, they don't feel comfortable enough for you to use it. Emergency situations, they'll probably say, yeah, go ahead, but let's still get that x-ray just to confirm it's in that right spot, okay? Now, as far as chest tube care, what kind of things do I need at the bedside?
Sterile water.
Sterile water, hemostats,
Gauze.
gauze, tape, Zeroform, all those kinds of things. So if my chest tube comes out of my patient completely, chest tube, atrium, the whole thing just gets ripped out, what do I need to do with it?
The zero from.
Zeroform, okay, and then what else?
Three-sided.
Three-sided gauze, right? It's creating that natural seal or that natural flap. As we inhale, it should create that seal, not allowing air to be introduced into our intrathoracic cavity. And then as I exhale, it's gonna allow some of the air out of that intrathoracic cavity. That's my main goal with it, okay? Now, what if my atrium gets disconnected from the chest tube itself?
Place the sterile
Put
water.
the chest tube in.
Put the chest tube in sterile water, all right? It's gonna take a minute to get that new atrium. Maybe you gotta go back to the subhypixis. What if your subhypixis was out and now you have to go to central sterile, and that's all the way across the hospital, and you have no other chest tube support there. So you gotta have something in reserve. Remember, that atrium is creating that water seal, not allowing air in and allowing some air out. Same concept with that sterile bottle of water. If you place it directly over that chest tube, it's allowing air out, but not allowing air in. It's creating that water seal. It's not gonna allow for any drainage or output to come out. There might be some gravity-wise because there's no actual wall suction connected to it, so there might be just gravity drainage coming out. But for the most part, it's mostly there for the water seal chamber. Very, very temporary process. You got to go get another atrium. You can't just let your patient walk around with a sterile bottle of water all day carrying it around with them, okay? Gotta have the atrium with it, all right? Other things, titling, is that okay?
Some, yeah.
Some titling is okay, right? That natural inhale and exhale, it should rise and fall inside that atrium. Everybody has seen the little white ball on the water seal as it rises and falls. That's what I'm talking about there, all right? Let's talk about bubbling as well. Continuous, constant, vigorous, violent type bubbling. What could be so y'all said no, good. What could be the potential reasons?
If it
Air
was
leaks,
small.
okay. What else?
If it wasn't in the right place.
Maybe not in the right spot, okay. How am I going to fix that?
Assess.
Assess, all right? Start with your patient, work your way down, all right? Maybe it became disconnected and you just didn't realize it because it was under the covers, all right? And then, maybe, like I said, come out all together. Maybe the chest tube tubing itself has a little nick in it, introducing some air into it. There's a couple different seals along the way, so where the chest tube meets the atrium itself, usually we take a lot of tape and sometimes even gauze to create that nice, beautiful seal, so we're not allowing air in, but we lost that seal or connection somehow, so I just need to reinforce that seal. There's also another seal down toward the end where the tubing itself connects to the chest tube atrium. Make sure I need to check that seal. All right. If I can't find nothing else wrong with that, and then I confirm placement, and there's still something wrong, the best and easiest thing to do, get a whole new atrium. It's very easy to hook up just a new atrium to a chest tube and be perfectly fine with that. Sometimes there is like a micro little chip or something inside the atrium from some kind of manufactured defect, and you just really can't see it. And so it's the atrium itself that's causing the air leak or introducing the air into my system. Okay. What about just slight bubbling here and there?
That's okay.
That's okay, right? It's allowing air to come out. That's the whole purpose of that chest tube, is to allow for that air to come out. Now, if I have air coming out every so often, and then like the next day or two, it's not. Is that a good thing or a bad thing?
Good thing.
It could depend, right? Maybe it's kinked off. Maybe the nurse before me clamped off the chest tube for some reason, not allowing air in. It could also be a good thing, right? Maybe that pneumothorax has resolved itself and there's no more air to be removed, and so it's not tidling or not bubbling anymore, right? Okay.
Leak checking, you said start at the person or patient. Do you hemostat, still leaking, hemostat, and basically rule out where it's leaking from?
Right, exactly. Yeah, basically what you're saying. You can hemostat, and then if it's still bubbling, I know that the leak is further downstream, all right? And then I'm gonna mark that or note where that is along there, go a little bit further down, hemostat it again, all right? Don't have any air. I don't have any bubbling anymore. So I know it's between the new place that I clamped and the old place I clamped. Somewhere along that side is there. And then sometimes I can reinforce it, but most of the time I'm just going to get a hold of atrium. Go from there. How much is too much drainage? What? That's a lot of drainage in 1 hour. How about that?
100 millimeters.
100 mils per hour, okay? 1,000, over 1,000, I probably need to change out the whole atrium itself, yeah. But over 100 mils an hour, I need to let somebody know, right? Yeah, okay, good. So what types of signs and symptoms from this case study alerted my nurse or you yourself to a possible pneumo? The desaturation, all right?
Lack of no lung.
Lack of nose lung sounds was diminished on that right side. Good. Let's take it a step further. What if I start to see some tracheal deviation to the left side?
Tension.
Potential pneumothorax, right? Then I could start getting into that needle compression that Chuck was talking about. It's gonna divert to whatever direction opposite of what's occurring. So if I had that right side, remember that whole right side is filling up with air, causing that tension and that pressure, and all my organs and stuff are going to shift toward the left. All right. What action should the nurse take immediately upon suspecting a pneumothorax?
Sitting the patient up and further assessing.
Okay, so further assessing, sitting my patient up, providing adequate oxygenation. He was already intubated and sedated, so maybe I can cut up my O2 a little bit to provide a little more O2 relief. Big thing is, I need to get that chest x-ray stat, and then I need to start getting my chest tube up and ready to go. Call that physician. Emergency situation, you don't need to sit on these types of things. We already talked about 3 talked about 4 already for chest tube maintenance, troubleshooting. Infection prevention measures. Let's talk about central line placement, or central lines in general. How do I prevent infection with it?
Weekly,
Weekly what?
change.
Dressing changes, okay?
Or-
Or as needed, right?
Or femorals daily.
Femorals are gonna be daily because they're nice and gross, and everything gets moist down there and just, they're just gross, so. And then also, even if it's not in the femoral, it's a gauze dressing that is constantly oozing and bleeding, then you'll probably change those more frequently as well. And that's usually by facility specific. Sometimes they'll change them like every Wednesday, regardless of when it was placed, so they get onto that cycle. So if it was placed Tuesday, that Wednesday comes around, yes, it's only been on there one day, but we're gonna change it again, and then we get back on that every Wednesday cycle, right? Central lines are supposed to be very temporary, although they stay in for a long period of time, usually. But 5 to 7 days is usually what they need to stay in for. So we need to monitor and constantly be aware of, does my patient really need this anymore, right? If you ask any ICU nurse though, if their patient needs a central line, they're gonna tell you yes, regardless of what they think. Because we just like that big access. But do they truly need it? What type of drugs are they getting? Are they getting frequent antibiotics that are not compatible with anything else? Are they on bicarb? Bicarb hates everything. All your pressors like to run together, but are they highly concentrated? If they start having these high concentrations, I can't run those through a regular peripheral IV. So those types of things. Chest tube.
You were saying bicarb is not normally ever used, right?
You'll get on a bicarb drip. Bicarb pushes, they usually don't run it for like codes and different things. It's
They
not
do
part of
the
Bicarb
ACE
protocol.
Because the acidotic state.
Yeah.
Okay.
That's really the only way to get your bicarb up. You can't really fix it any other way. You can do some ventilator changes to hopefully blow off some CO2 and changes your CO2 settings, but it's usually not very effective. Chest tube management is going to be the same thing. Continuously monitor to make sure your patient needs that chest tube. Really, this is not going to be your call on when to pull it, but you got to remember, oh, if my patient has gotten an X-ray today, I probably need to get another chest X-ray just to see how well or how advancing my pneumo is occurring. And then remember, it's not our job or duty to get that consent form, but it's usually going to rely on us to educate our patients about the risk and benefits of a central line placement. So kind of keep a rehearsed speech almost in the back of your mind. And you start working in these different fields and you start becoming a real nurse. You have almost these speeches that you say every single time for these patients. So kind of think about those things. Remember the pneumothorax is the infection risk, but it's very beneficial in the short term for these types of patients. Okay? We're not going to run all the way through her. It's roughly the same thought. You want to read some of these questions though. 42-year-old male is admitted to the emergency department after a motor vehicle collision. He is alert but in moderate respiratory distress. Chest x-ray confirms a left-sided hemothorax. A chest tube is inserted and 1,200 of dark red blood drains out immediately. That's a ton. The patient's heart rate is 122 beats per minute. His BP is 88/54, respiratory rate 28. O2 was 90% on 6 liters. Nasal cannula, that's hard to do. Which of the following nursing actions are most appropriate at this time? Remember, this is select all to apply. I hear A, everybody like A?
C.
C, prepare to administer IV fluids and possible blood products. I like that. What else?
E.
I heard E. Everybody agree?
Yeah.
Okay, I like them. So notify the provider of the amount of initial drainage. That's a lot, right? 1,200 of initial output. That is a ton. Remember, 100 milliliters or more in an hour, I need to let somebody know. More than likely, he said, yeah, that's probably pretty good. I would expect that. He had a large hemothorax. And so he's gonna lose a large amount of blood. B, clamp the chest tube to prevent further blood loss. Do we ever clamp a chest tube
Unless
for
it's
an
empty.
extended period of time? No. Okay, so we can mark that one out. Prepare to administer IV fluids and possible blood products. Why do I need to worry about IV fluids?
Because he's
There's a
hypertensive.
He's in hypovolemic shock, right? Because I lost so much blood initially. I lost 1,200 of blood in a very short period of time. Basically, my blood volume is gone. all right? And then I can see that it's being affected because my BP is 88 over 54. Now my heart rate's probably compensating, so that's why my heart rate's elevated at 122, because it's trying to work a little bit harder, trying to increase my cardiac output a little bit to affect my blood pressure by that. Because remember, cardiac output is heart rate times stroke volume. And then blood products, probably my H&H is gonna be a little off. And so essentially he doesn't need the fluids, that's gonna be a temporary solution. To replace that volume, what he really needs is blood. But it takes a while to type and cross and then get those blood products ready and available. So a short-term fix, I can give him some fluids initially. Okay. And then, let's see, document findings and continue to monitor every 2 hours. Yes, that's okay, but this is an emergency situation and I need to do something now, all right? I don't need to document this as a normal finding and be like, all right, we'll see what happens in 2 hours. All right, your patient's probably gonna die in 2 hours. So anticipate the need for emergency surgery. Maybe there is some reason or another he's bleeding like he is. Maybe they need to go back in and evaluate a little bit further to see those type of complications. Okay. Nurse caring for post-op patient with central line who begins experiencing sudden shortness of breath, chest pain, and diminished breath sounds on the right side. Select all that apply. A, apply high flow oxygen, okay? That makes sense, right? B, notify the provider immediately.
D.
Probably need to let somebody know. What else?
D.
D. And then E, prepare for a stat chest x-ray, monitor for tracheal deviation and hypotension. All right. Why hypotension? This is a right-sided or left-sided pneumothorax. Right-sided pneumothorax.
Because of compression on the heart.
Compression on the heart. Remember that intrathoracic cavity pressure is increasing, causing stress on that heart, decreasing my cardiac output. Good, good. Nurse caring for patient with chest tube for a large left hemothorax. Which assessment finding requires the most immediate intervention?
C.
Sudden onset of hypotension and increased chest tube drainage. Everybody agree? I agree with that too. 50 mils an hour, not really important. Absent bubbling in the suction control chamber. Am I gonna get any bubbling with a hemothorax? Very little, if any, because it's a hemothorax. Remember that, that's blood. All right, so probably not gonna get a whole lot of air from that. Maybe on insertion, I introduced a little bit of air into the intrathoracic cavity, so initially I might get some bubbling, but for the most part, shouldn't have any. And then titling in the water seal chamber with inspiration. Should be on exhalation, should be rising. Okay. Nurse is caring for a trauma patient with rib fractures. Patient becomes restless with distended neck veins, tracheal deviation to the left, and absent breath sounds on the right.
C.
C, page the provider and prepare for a needle decompression. So this is what we're talking about with that tension pneumothorax. Patient becomes restless. He's anxious. He's not getting a good breath of air because he's got entire air full of intrathoracic pressure on that side there. Distended neck veins. It's causing that pressure. Tracheal deviation. It's pushing everything to that left. And then nothing on the right. So I'm going to have that tension pneumothorax on that right side. So go ahead and call him so he can come in and stab your patient in the chest. It's pretty cool to see. Excessive continuous bubbling in the water seal chamber of a patient's chest tube system for a pneumothorax. What should I do?
B.
B. Check the system for air leaks starting at the patient. I like that. What else? B, C, and E. Good. Assess the insertion site for crepe history. What is that?
It's the emphysema, subcutaneous emphysema.
It's the subcutaneous emphysema or the Rice Krispies inside the chest. So it's kind of leaking into that subcutaneous tissue, that air. I always think snap, crackle, pop. So that's me. And then, oh, what happened? Oh, yeah, okay. Call the provider if the leak cannot be identified. If you can't find out what's happening, tell the physician to come in here and he can fix it. Okay? That's why he gets paid the big money. All right. Last one here. Patient with chest tube for hemothorax suddenly coughs and dislodges the chest tube. What is the first action the nurse should take? Apply a sterile occlusive dressing taped on 3 sides. I like that. Initial action, the first action we should take. Yes, we are probably going to prepare for the reinsertion of the chest tube. We're probably gonna check those vital signs in that O2 sat. And then we're probably gonna know the provider and maybe the rapid response team if we need them. But my first action, before I do anything else, because if I don't put that dressing on there, I can introduce a ton of air into my chest cavity and don't want that to happen, okay? Questions about that? These are gonna be some of the types of questions that you're more than likely gonna see.
You could put all of those on the test and we.
Please, and maybe just change the patient's name, that's it.
We can just,
So
Maybe change up the order.
the main thing is, how do I manage my chest tube? If something is wrong with my chest tube, how do I fix that chest tube? And then mechanical ventilation wise, if something is wrong with my vent, it starts to alarm, how am I going to fix those situations? How do I know what's wrong with that system? Why is it alarming? How am I going to assess my ventilator? That kind of stuff, okay? You wanna eat?
Yep.
Let's go for it. As you're beginning